Uh, have not the of the and,
when he was 7 years old, and he did a treatment. They never this case. So when this kid turns to 11 years old, this patient come again um, to the office of my colleague, and the patient come with pain. He comes back with an abscess, pain, and when the colleague took the X-ray, he saw a big resorption on the root. So he sent this case to me, asking me if there's something that we can do to save this case because it's only this patient, 11 years old. And of course, the patient and their parents don't want his kid to lose the tooth. So I told to the colleague, okay, send me the case and let me take a look. Okay, so when I took the periapical x-ray, as you can see right now, this patient comes, and of course, you can see the end of treatment is not the best end of treatment. You can see all the good persia these colleagues left behind on the food chamber, on the coronal part, and also, it's a very obviously resorption that this patient has on the root. Also, a big lesion in the periapical area that you can see. So, in this case is a very difficult case because these two also have a lot of bone loss. In these type of cases, we have to think about, I mean, what kind of treatment we have to do. We also have to make a good diagnosis to make sure what treatment plan we can make on this patient. So this case was a very challenging to do because all this because of the prognosis of this tooth was very bad, and I have to explain to the parents that the prognosis is not good to keep this tooth because of the age of the patient. Okay, so running to the next slides, you can see this is the first initial photo, clinical photo that I took to the patient. This patient come with a sinus tracts. This patient has also a mobility on the 1.1. Okay, there's a little bit of delay. Okay, and after we took this initial photo, you can see a closer photo next to the next slides. You can see the sinus tracts that we have here. So of course, for this patient, we can any fraction of the two. Another treatment plan sometimes people say is to do a retreatment. Okay, but it's very difficult. You will see as we go forward to the presentation. So in this case, in this picture, I just put a gutta percha just to follow part of the infection, but you know it's very obviously you can tell just by a periapical X-ray the big resorption that this kid has on the root. So in this case, I also have to make sure that the tool 1.2 has no problem at all, because on this periapical X-ray it's very difficult also a lesion in the periapical area of the tooth of 1.2. So in this case, I made some vitality tests, and this tooth was not responded to the vitality test. So I also ordered to make a 3D X-rays to make sure to make the right diagnosis and see if really we have an affected tooth also of 1.2. So in this case, we make a CBT, and then we start trying to see on the 3D on different angles to make sure and see how big was the lesion and see how much the lost bone was extended, and also to see if really 1.2 of the vitality that was necrotic, to see if that 1.2 also have a big lesion on this tooth. Okay, so you can see that this patient, young patient, has, and of course, as you this patient has part of the root on the palatal side of the resorption. You can see all the gutta percha also outside the apex, and you can see how we have a lot of bone loss on the buccal side. Okay, and also the 1.2, you can see on the 1.2 that we also has a big lesion, and this tooth was not vital; it was necrotic due to the same trauma that this patient has years before. Okay, the treatment plan that we that I make on this case on 1.2 was to make an endo treatment, just a normal endo treatment. Treatment to try to save this tooth. Okay, you can see, of course, always we have to do a proving just to make sure how much deeper and see how much bone loss. So if you see on the palatal view, you can see on the palatal view also how this kid can case I choose okay? Because on the tomography, on the 3D X-ray, I saw we have a little bit of bone, so I decided to make a submarginal flap for this case, okay? A really microscopical surgery. We are going to apply all the same management that we will do for a apical surgery, but in this case it will be different because we don't have a apical portion of this root. Basically, what we have is a middle third of the root, okay, because of the resorption. So if this tooth is resorbed of the middle third of the root, it will be very wide, okay? So just to remember, when we try to do an apical surgery, we always try to eliminate 3 millimeters of the apex because it's where the access, where the lateral canals of accessories, canals, or ramifications normally we have, and normally if the bacteria are there, that we always have to make sure to see working. So before I go to the case, it's important to note that we need to have some instruments, of course, micro instruments to make the kind of treatments. So, of course, in this case, I always recommend to use a microscope. Microscope is always mandatory to do some microsurgery, okay? It's no different from this case. Um, ultrasonic tips for apical surgery, and one of the ones that I like to use is this EndoSuccess apical surgery instruments. And I also always like to recommend to have something to separate the mouth or to open the mouth like a retractor. And normally I like to use the Optograde from Ivoclar because it helps me to open the mouth of the patient. And as you can see on the video, I always, when I try to do some, always use the Optograde, and I always use some gauze and make the patient bite the gauze so this patient can be more comfortable instrument to separate the tissue, to do some packing of the bioceramic instruments, etc. So I recommend this kind of instruments always that you're gonna make some microsurgery. And of course, we have to use also microblades in order to be more conservative to the soft tissue, okay? And also we need a handpiece, okay, in order to remove some part of the root or the bone. And also, I would like to share the plano. A lot of you, maybe you know the plano. And the plano is excellent not only when we're doing an endo treatment, but also when you want to mix the MTA in something that is sterilized. Okay, you can sterilize plano and plano in the middle of the plano. You can place perfectly your MTA and also mix the material, the bioceramic material, in order to make the case. Materials that we can use in the market um, to do the obturation of the apical portion, like MTA, biodentin, Jetty Store, and some materials that we can use for regeneration, like bone. Okay, so going back to the case, what I did on this case, I make a submarginal flap, and also after that, I remove all the granuloma tissue, okay, from the 1.1 and also from the 1.2, okay. After I remove all the granuloma tissue, okay, I also, as you can see here, this is the middle third of the root. And if we go from the coronal root portion, you can we have a very short root, but we also have a very um, irregularly apex, and also you can see that we have a very wide, because this is to make a retreatment, because making a non-surgical treatment for me to do an apical plaque there, because it's very irregular, it's very big, and also we have part of the root on the palatal side that it has been resorbed, and I have to remove that because that can be a part where bacteria can be there and also keep the lesion growing more and more. So after I eliminate everything, okay, I seal. In that case, I use the biodentin. I put some xenograph bone with 6.0 nylon, okay, and then I use some chlorhexidine, 0.20%, okay, to help the tissue to heal a lot better. And this is the post-op, okay. I finish the surgery, sealing with biodentin. As you can see on the coronal portion, I didn't remove the gutta percha because I was going to remove the other part of the gutta percha to avoid some pigmentation or discoloration on the coronal part, and a second appointment. Okay, so the first appointment was just to treat the case by a surgical way, okay? And then this is the bone that we place in there, okay? And then after that, this is a recall a week later, just to remove the sutures that I put there a week ago, okay? 1 week recall, okay? So right now, I'm gonna explain this surgical part very quick on, I'm gonna explain this very quick on a video. So as you can see here in the video, okay, I was making the diagnosis that I just showed you guys on the presentation. I'm just gonna forward it a little bit more. And then with a microblade, a submarginal, okay, submarginal flap in this case. And then we start to open the flap, very gentle, okay. I choose the submarginal because we have bone there. And then I try to is, as you can see here. And then I start removing all the granuloma tissue, okay? As you can see there, you can see part of the gutta percha that it was out of the root because of the resorption, as you can see also in the periapical x-ray. So there, I'm cutting all the granuloma tissue, removing everything, trying to be the most conservative possible. But remember that we also have a lesion, big lesion of 1.2. So in this same surgery, I'm trying to open and removing just a little bit of bone, so it'd be more easy for me. So in this case, I try not to open and remove more bone that is not needed. But also, as you can see here, I can now see part of the root of 1.1 that was resorbed on the palatal side. So I just eliminate that root to avoid any reinfection, okay? And then I start removing more of the granuloma tissue, okay? After that, I just check in the periapical. Forward a little bit more, I was eliminating all the granuloma tissue. After I remove all the granuloma tissue, okay, I see the root from 1.1 and 1.2. And then what I make here with a 45 angle handpiece, I'll just try to make more regular all the apical portion, okay? So it will be more stable for me to place the material. Then I went here with a ultrasonic tips micro. As you can see on the root, on the mirror, you can see how I finish placing very well the material, and then I put the xenograph bone, and then I put a membrane because we have a big lesion there. And then after that, I suture the case, and then I put some gel from chlorine, 0.20%. Okay, so this is how we do it. And now to finalize, to conclude the case, after 15 days, after did the endo treatment for 1.2, and also I removed part of the gutta percha that we have of 1.1 on the corona to avoid any discoloration of the tooth. But as you can see, the isolation, I make a multiple isolation. I didn't use a clamp for anterior directly to the tooth that has mobility, because see, I can do the extraction just by placing the anterior clamp. So that's why I make a multiple isolation to avoid placing a clamp directly to the tooth because of the mobility. Okay, so as you can see here, we did a multiple isolation, and then with ultrasonic tips, what I did was to remove all the gutta percha from 1.1 in the corona part, and also to make sure the material, the biodentin, was really hard and very, very well placed and sealed. Okay, after I make sure everything was great, I started doing access for the 1.2, and then I finish the endo treatment on 1.2, and also I place also some composite to finish it on the axis. Okay, and then this is another control that we make on the patient. I have another video to show, but I guess there's not too much time to use the other video, so I'm just gonna forward it. And also, you can see how this was really working very well after a few months. Okay, you can see a little bit of scar, not too much. You can see the post-op, how we finish sealing with composite on the palatal side. And you can see this X-ray control that I make this follow-up 6 months ago. You can see a little bit of the resorption of the material, the bone that we place in there after 6 months. And after, you can see in this other slide, the initial way that the patient came to me when he was 11 years old. Then you can see the X-ray of the post-op, the post-treatment, and then you can see 1 year recall on the next slide, okay? And you can see these two, even they don't have a long root. The root is very short. There's no mobility in the tooth in 1 year. And then after a year, I make another 3D X-ray just to make sure that we really having a good healing. So as you can see here in the next slides on the tomography 3D, you can see how the initial and you see 1 year later how we have a really great healing of the tooth. And not only of 1.1, you can also check on 1.2 also how we have a really great healing and a really good regeneration of the bone in the apical portion. Okay, as you can see here in the next slide, you're watching the 1.2 tomography. Okay, great healing for that. And also you can see on the axial cut, you can see also a really great regeneration of the bone in this. Okay, and then after that, this picture, this clinical picture is the patient 1 year later. Okay, you can see how we have saved this. Also wants to have ortho. I explained the parents we cannot use the ortho directly to the tooth because we cannot make no forces to the tooth because otherwise everything that we did so great it will be terrible if we put ortho. So I talked to my orthodontics that work with me to place ortho, but not to move that tooth, not to place anything. As you can see here, um, okay, it's just to have it there. So as you can see in this picture, you can see that the bracket is not stick to the tooth, okay? But as you can see how in a few months we are trying to make better this tooth. See in this other picture, you can see the beginning and how now with ortho, how we make this tooth look a little bit better, but we are not placing more forces to 1.1, okay? And this is how the patient looks nowadays. He only have like 4 months with ortho. But the good thing is that this case has 3 years follow-up right now, okay? And this tooth has no mobility. You can see a little of the bone that we place. You can see the lesion is completely healed. And this is how we manage this case, okay? So this is the case that I want to show you guys. And let's see if we have some questions. Fabio and Simone.
Sharing this very complex case. My opinion is that
This
whenever it's
patient
possible, we need
was
to
7 years old. Is when he came to me, 11 years.
Well, I just wanted to thank Dennis for the very beautiful case, very complex and very well managed. I only
Hello,
have
Diego.
one comment to do.
Hello. Simeone.
Dennis. Can you actually explain why did you
Okay,
do the
one
root
second,
canal?
guys. Let's see what happened with the sound. So we can see the answer and make a little bit of discussion of the case.
Dennis?
Go.
We got a slight problem with audio. Dennis, can you
Let me
hear
know.
us?
Hello.
Hello, Dennis.
Diego, I can hear you.
Yeah, okay, so maybe we
Okay,
take the discussion.
I'm gonna.
So in the meantime, maybe Fabio and to Dennis.
But I can see.
Simeone,
Anything.
actually, I cannot hear you from here, but I can hear you from my phone right now. So I can list what from the phone, and then I will answer the question. Hello.
Hi Simone.
Okay, I'm gonna.
Diego,
Sì,
ma io vedo la
in
slide, non
English.
vedo loro.
Sì.
I can see the slide, but I can't see on the video.
Simone and Fabio, do you want to say something about the case eventually while we reconnect?
So well, I know we can choose this case. That I really can try to no fracture of the granuloma. I know by removing all the granuloma tissue, a simple endo treatment. I made that of a week, and then I finished the treatment on 1.2 on a second appointment. So in this case, you can try to make the 1.2 the surgery. I think there's no thinking to make a apical surgery to 1.2. So for me, making it before or after the surgery of 1.1, for me, it will be no different. No different because 1.2 doesn't need no apical surgery. So it will be no different if I make the 1.2 endo treatment before the surgery of 1.1 or after, like I did in this case, after I eliminate all the granuloma tissue, after I did the surgery for one, I can still make the normal endo treatment without no problem. Okay, unless I was thinking to make a apical surgery also in the same surgery for 1.2, I will I decide to do.
On the show?
Great. Well, I will be looking for more questions on the really happy that Dennis strived to try and save this particular tooth due to the age of the patient and of course to the general situation of the whole case. So I totally agree with the treatment planning. We are not sure whether this tooth will be there forever, but we bought some time for the patient so that he can arrive to an age where an implant is a more predictable. That was the only option we had, and I want to congratulate again Dennis for the case. I don't know if Fabio is online.
No, Fabio is not online. He said ciaone. So,
Okay.
okay, maybe we can actually have, we will continue the discussion directly in the post page, since
In
we
the group.
actually went
Thank you very
too
much,
long.
Diego, for arranging all
Thank you very much,
this.
Simone, for being with us. Thank you very much, Dennis. And see you directly in the video of the page.
We are now, Diego, in the university. Actually, I'm still in the hospital. We're, the situation is quite difficult now, but
Yeah, it's great.
Oh, thank you.
we are resisting.
Thank you very much, Simone.
Okay. Good luck then resisting Corona. Bye.